Our first presenter is Dr. Sarath. He will be discussing on OCT, the quantitative and qualitative analysis in the case of diabetic macular edema. Over to you, Dr. Sarath.
I thank Dr. Vinita for the chance. Today I'll be dealing with OCT, qualitative and quantitative analysis in DME. OCT plays a very important role in managing DME, from identifying the disease at a very early stage to predict the visual prognosis and to monitor the treatment response. First thing, when you see a DME, see whether it is a tractional DME or a non-tractional DME. Tractional DME surgery comes the mainstay of the treatment, and a non-tractional DME, look whether it is a center involving DME or a non-center involving DME. Center involving DME is defined as any retinal thickening and the center 1 millimeter subfoveal zone. Center involving DME, anti-VEGF injection stays the mainstay of treatment. If it is a non-center involving DME, you can either observe the patient or can do a focal laser. Morphologically, diabetic macular edema is divided into a spongiform edema, cystoid macular edema, and a serous detachment. With the breakdown of blood-retinal barrier, fluid starts accumulating in the outer plexiform layer in small cyst. This is termed as spongiform edema. With the further disease progression, more fluid start accumulating in the outer retinal layers. These small cysts coalesce to form larger cyst. This is termed as cystoid macular edema. With the further disease progression, more fluid will get accumulated, and this fluid break the ELM and go to the subretinal space, causing a serous detachment. Further, if patient is having hypoalbuminemia, increased hydrostatic pressure can lead to more fluid accumulation in the subretinal space. So the morphology, with the morphology we can assess the severity of the disease and some clue regarding the systemic condition of the patient. Hard exudates are lipoproteinaceous material deposited in the outer retinal layers. In the OCT, they appear as hyperreflective dot or clump echoes. Usually, they are more than 30 micron in size, and they will have a back shadowing. These hard exudate slowly get absorbed with treatment, anti-VEGF injection or focal laser. Usually, they very well clears with focal lasers. If not treated, these can form clumps and migrate to the fovea, or can transform to cholesterol crystals and can cause permanent visual loss. Another OCT biomarker is intracystic hyperreflective material, or ICHRM. It's not only the fluid that get accumulated in the extravascular space, also along with the fluid, fibrin, macrophages, heme, protein, etc. will be transferred from the intravascular to the extravascular space. These get accumulated within the cyst. They appear as hyperreflective material located within the cyst. These are called intracystic hyperreflective material. If the cyst is partially filled with the hyperreflective material, usually they respond well with the treatment. If the cyst is completely filled with the hyperreflective material, usually the response to the treatment is less. Then these hyperreflective retinal foci, they are actually activated microglia cells. They appear as hyperreflective dot echoes within the inner retinal layers. To differentiate from the hard exudates, these HRF are very small. They are usually less than 30 micron in size, and usually they do not have any back shadowing effect. The presence of HRF indicate that the disease is more common, more of inflammatory mediated than VEGF mediated. So these patients will respond well with dexamethasone implant rather than anti-VEGF injection. Disorganized retinal inner layers. This is a negative biomarker for visual prognosis. This indicates that there is macular ischemia. In OCT, drill can be identified with there won't be a clear demarcation between the retinal layers. The presence of drill indicate a poor visual prognosis to the treatment. Another two indicators of chronic diseases, pearl necklace sign and ELM and EZ discontinuity. Pearl necklace sign, there's hyperreflective material are arranged in a continuous ring-like pattern around a cyst. This indicates a chronic exudative maculopathy. And presence of a ellipsoid zone discontinuity or a ELM disruption also indicate a poor response to the treatment. Thus, OCT in diabetic macular edema give lot of information regarding the from diagnosing the disease, regarding the severity of the disease, some clue regarding the systemic condition of the patient. So it plays a very valuable role in management of DME. Thank you.
Thank you, Dr. Sharath. Any questions anybody wants to ask?
Do we generally laser the hard exudates all that often?
If it is a focal maculopathy, you can definitely see a aneurysm. You
Yeah,
can leak it.
in that
If it is
case.
encroaching the fovea, you can laser it.
When you have a pearl necklace sign,
Yeah.
but at the same time it's involving the center,
Yeah.
you have a rationale of putting injections or not? Because you said it's chronic.
Yeah, go for injection. If it is the center, later it can form hard exudates clump there. So it's better to treat it.
Okay, that's all. We can move on to our next presentation.